Thank you, Mara, for the invitation. It's really a pleasure for me to share this, hour with you and your viewers. I know you're doing a fantastic job on education. I know you for the last 20 years, and I know what you're capable of and the kind of quality of material that you always produce. So for me, it's really an honor to be with you and your viewers. So I think it's important that you guys know a little bit about me so you can apply the information I'm going to give you to what you do. Okay. I'm a prosthodontist. Actually, I came here to this country. Well, first of all, I'm from Ecuador, just like you, Mario.
Yes.
I came here about 11 years ago. I did my AGD in Rochester. And then I did my pros residency at Iowa, and I finished 2014. Right now, I'm a faculty member at OHSU, and that's in Portland, Oregon. I'm a prosthodontist. I'm in charge of the aesthetic and orthodontic courses for the students. So a lot of the cases I'm going to show you are coming from students. You're also going to see cases from my own faculty dental practice, and where I only see referral cases. And I also practice outside the school too, in a more in a private setting. Is that is more like general dentistry because I do surgery, I do restorative, and not only do referral cases like I do in the school, right? So the topic for today, we're going to talk about some of the things that I see when we have implants, in the moment that we restore implants. And I think even depending on the experience that you have, either you're going to see cases are really hard to restore. And I think it's going to happen at any point of your career, either when you're you know young and just out of school, or when you have more experience. I think at some point of your career you're going to see implants that are not ideally placed. And I think it's something that we can see very common these days.
And
um,
I just want to interrupt you there just for 1 second because I do want to, put that out there and make it very clear. And this is not only if you decide as a restorative dentist to place your implants, that, you may have some implants that you place yourself and that are not ideally placed. But most importantly, for restorative dentists that, dentists out there that only do restorative and that they are receiving cases with these implants placed in non-ideal positions. So this is something that really you see this a lot in practice. So I think, and I want to thank you again because I think this is a very, very important topic, and we have to learn how to deal with these situations.
Yeah, and I think it's also important to disclose that I don't do my own surgeries. I don't place implants myself. I have a team of periodontists that I refer to, one or two that I work with. So I restore most of the cases, but I plan the cases myself too. And of course, that's part of what we do, and it's a very important part of the implant therapy. But the industry, sometimes you want things to be ideal, but that's not the reality every time. As a prosthodontist, I received so many cases that were referred from outside referral, and the implants were already placed, and the implants were not in their ideal place, and I had to deal with what I have. So throughout the years, I collected all this information I'm going to give you today. And it's not really to tell you that the presentation is not really telling you, what to do or how to deal with it. It's just giving you some clinical tips on what to focus on. Okay. And the things I have seen throughout my career. Okay. So, in the course of your clinical life, you're going to see implants that come to you like this. They are not only to facial, but they can also be at the incorrect depth. So you're gonna deal with things like that you receive that patient in your office and you're like, oh my god, so what now? What am I gonna do now? So let's go over some of the challenges that we see when we see implants that are placed like that. First of all, when you do a house situation like that, you know that now you have to deal with the screw hole axis. Right now it's coming through the facial, not ideally coming from the lingual where you can hide it, right? The other thing is that the thickness of the material. Can you see my pointer, Mario? Can you see
Yes,
my
I can.
pointer?
Yes, I
Yeah,
can. Yep.
okay. All right. The other thing is that the thickness of the material around the cervical area can also be thin, and that can also give you not only strength, problem of the materials, but also some aesthetics. Because if you have some, titanium components over there, you may have some issues with the final shade. And then I want to show you this case right here that I restore, and you can see that, of course, the gingival margins are not the same, and then because I made the mistake of not um, educating the patient enough about the value of doing a crown lengthening in this too. That's actually what we plan in the future, but unfortunately, the patient did not go with that. The implant is at the right spot in terms of depth, but it's a little bit tilted, facially, and that's actually what gives you that kind of like grayish look around the cervical area, and it's because I haven't been able to mask that in a very effective way. Okay. The other thing is that we also consider is if the implant is not placed directly underneath the restoration, you have this off-axis load, right? With this internal cantilevers, and when I say internal cantilevers, I'm talking about within the same restoration. Okay. Um, for example, this case right here, this is one of my old cases that I saw in residency, and you can see how that implant in the premolar has been placed. Uh, and you can see if you put that matrix, you can see that it's completely off of what you want it to be ideally. Okay, and you can see how when restored, that you're gonna have a very significant large cantilever on the median. Okay, so that we know now by some papers is that you may have some more sclutening because of that internal cantilever. Okay, so it's very important that you consider that. Yes, Mark.
And yeah, one of the things that I want to mention here is because this, even though we're talking about non-ideal implants, this really, when I look at this photo, it really makes more sense to me the importance of planning. Even if you're a general dentist, even if you're just going to restore a single implant, the importance of taking the time for good planning so that things like this can be avoided. Yes, they can be fixed, they can be corrected, but they're never going to be ideal. You have to expect long-term, issues with this biomechanical, most likely issues with implants like this because of the lack of, I would say, planning.
Absolutely. You know, this situation has so many problems right now that right now, with what I know, I will probably will consider, removing the implant and placing the right spot in this particular case. It's not possible in every case, but in this particular case, maybe because this is an old case from residency, I probably will consider just removing the implant. You know. Mhm.
Right? Yeah,
Okay.
that's always an option, a difficult option, but an option
Yeah.
as well.
Yeah. Yeah. So in a situation like this, when you have an implant that's placed to facial, like for this patient, so you have options of either cement or screw, right? So what are the options that we have, and how do we decide to do? So first of all, I have to give you some ideas on, how cement restorations and screw routine restorations are designed. What are the options that we really have for abutments, right? Because that's what we need to start thinking of. How's the abutment that I have going to be designed for that final restoration? So if you have a cement retained restoration, one of your options might be one of these Atlantis abutments, right? They're one piece milled, titanium abutments, either you just the titanium or the anodized titanium, right? Uh, or you also have an option of like a one piece zirconia abutment. Okay. Now we are moving away from doing this type of prosthesis just because we don't want the contact of zirconia, titanium, implant connection. We just don't want that direct contact of the zirconia with the titanium, because we know that the zirconia is so strong, it's so tough, right? That those micro movements of the abutment and the restoration will create some wear of those internal threads. And that's is very obvious to see. If you have worked with these abutments before, you can see that even just trying in the crown and trying the abutment, you will see already marks around the abutment. Okay, so
Yeah, you're right. You
imagine.
can see like gray scratches around the
Yeah,
abutment. You're right.
exactly. You can see gray sketches around the abutment. So how's that gonna translate, in a long-term use of the restoration? So for me, I move away already from this type of components. If you want to do a zirconia abutment, there are other options for sure. And this is a very popular option right now. I think if you're doing static dentistry with and you're managing software using zirconia abutments, this is most probably the design that your lab technician is using. We're milling zirconia abutments, and you're controlling the margins, and you're cementing that abutment. So this will be a two-piece abutment, right? This part of this zirconia base will be cemented with resin, outside the mouth, of course, and then you have a crown on top. Okay, a cement crown on top. All right, so you have two parts that are cemented.
One thing that I want to mention there that I know that you probably have been aware of this, Jorge, is that I love these type of universal titanium abutments that they can always mill and bond the zirconia to. But one of the issues that I have found a couple of times in some clinical cases is that when they're not bonded correctly, you see that this can spin. It will debond, and that is a problem. So just keep, for all the listeners, keep that in mind. Make sure that you interact with your lab technician. Make sure that they're doing a really good job bonding these two pieces together, using the appropriate, bonding primers for the zirconia, for the metal, so that there is a really good and tight bonding between both pieces, because that is a problem.
Absolutely, absolutely. Actually, that's part of my next slide. But in the screw-retained options, remember that we had the typical UCLA design. I used this design a lot during residency. But I see a decline of the use of this restoration, particularly for the cost of the metal nowadays, right? So most of the times I see zirconia crowns or another type of restoration, which actually is done in a different way as a screw-retained restoration. So you can either meld or sometimes press lithium silicate to these structures, and then the whole structure is cemented outside the mouth, and then you can just do it as a screw-retained restoration. There are multiple combinations, of course, but this is mostly, I think, what we see. Okay, and what Mario, you were saying is that you know I think it's important that we actually chose a company that have some options in terms of the height of those devices. Okay, not just to mention a particular company, because the company you see right here, they don't pay me to do this, but I think it's an important decision as a dentist that you chose a system that gives you some options in terms of the height of those variable bases. Okay, this particular company has 3.5 and 5.5 of this part. Remember that, like you were saying, you need to also have a communication with your technician about understanding the process of bonding those zirconia pieces to the titanium abutments, right? We need to follow a protocol. We need to follow a surface treatment of the material, so we can achieve appropriate bond strength to the components. The other thing is also the height, right? If you have a very large crown that you're bonding to this very short piece of abutment, it's doesn't make much sense to me, right? So even though you're relying on bonding, and we know that bonding of zirconia to titanium works, but you have to also have some kind of clear idea of the design, right? If you're bonding this huge piece of zirconia to this little short titanium abutment, things are gonna fail, right? So there's some more options where you can have a higher base, and of course this is gonna depend on how much intraocclusal space you have, right? But those are decisions that we need to take, and we're not considering. The other part also, Mario, is that emergence profile height. Okay, this options will also give you some range on how tall you want that part to be. So you can not only control this part, but also the part of the tissues. Okay,
And
and also remember,
what
yeah,
brand, Jorge, is the one that what company is the one that makes the abutments that you showed initially?
that's a Straumann.
Strawman Company.
Yeah,
Okay.
they made different tissue cups heights, so you can, and that's important. That's important. Why? When you have a subcrestal implant, an implant that is below the crest, okay, if you use a 1 millimeter, a tissue cup height, the abutment will crush the bone around it, okay,
Yep.
and this can translate to more bone loss, okay.
Hmm.
So we need to remember that the part for the restoration here from the head of the from the platform of the implant, and that this part will contribute to bone stability, and this part will contribute to soft tissue stability, all right. So this is, how the profile of the restoration is coming out from the implant, and this is how it interacts with soft tissue, okay. So they both can have a high impact to bone, okay.
For sure.
So it's very important that you consider that if your implant is 2 millimeters, under the crest, then you should consider to use a 2 millimeter tissue cup height abutment. Okay, if you use one, most probably what's going to happen is it's going to be super tight, and the tissues around is going to be, collapse. Okay, they're gonna be strangled by this abutment. Okay, all right. So this is actually need to disclose. This is one of my student cases. So this is the case that you saw, right? In this patient, we decided to do a cement retain restoration, and we're also going to discuss some of the options that we have. Oh, another thing that I forgot to say, another option that we have is also angle screw channel for screw return restorations. But we're going to discuss that later on the presentation. Um, so I decided to do cement retain for this case. It's just because of the angle was so much facially that I prefer not to do angle screw channel, and I'll tell you why later on. Okay, so this patient received a veneer number 6, veneer number 7, a crown veneer number 8, the implant crown number 9, another crown number 10, and a veneer number 11. And you can see here, here's the student doing the preparations through a mock-up, and also we here we're doing the final impression. And after that, we review the lab work, and we're gonna use, in this case, we're gonna use a customized zirconia abutment, okay, cemented on a variable base, and again, it has the correct cuff tissue height that we selected for this case. And now we're gonna deliver the final restorations. You can see in this particular situation, I chose to pack cord, okay? And this is a very delicate situation, because remember that right now that tissue adherence is not formed yet, right? We're just placing the abutment, so there's no epithelial seal right now. And if you push the cord too deep, you're not gonna be able to retrieve it back unless you take everything out. Okay,
Right.
so if you have designed your margin to be, because that's also the beautiful thing about doing this, digital customized zirconia abutments, you are able to design what is the depth of that margin. Okay, typically I leave it about, zero point 0.5 millimeters um, underneath the gingiva on the facial, and you can be completely super gingival on the lingual, because that doesn't really matter. Okay, um, so you need to make sure you put the core around, and then you use the cement to cement the restoration. And we're going to also talk about some cements later on. Again, and here's the final case. We had some issues, of course, in terms of matching, and I think I've been discussing this case with some of my colleagues, and we discuss it a lot with the student, right? Because there's a lot of things to learn from this case, and he definitely learned a lot of things from this case, things that we can improve. But you can see that if you are careful enough packing that core around the gingiva, you will be able to have a very clean margin and not a lot of excess. Another thing also to plan is how much cement you put in that crown, and I will show you some tips too. Okay. All right. So a few things to think about when we're doing cement retained restorations. And first of all, the number one thing that pops to your mind is, what about the residual cement? And we know how destructive can that be, how harmful to the tissues, and the not only the bone but the soft tissues can affect the residual cement. Okay, this is a patient of mine in the faculty practice who came. He wanted to replace this FPD. He had this you know, FPD, aka bridge, right? There's a cantilever FPD from number 9, and the patient lost number 10 years ago, and he wanted to do an implant in this site. This is a radiograph that I took from the patient's chart about 10 years ago. The patient then went away, went to a different practice, and then came back to us about about a year ago, and he had this implant
Wow.
placed in number 10. Okay, the implant was placed about a year before he saw us, and it was done twice. He had one implant first fail, and then got a second implant. And you can see that there are a lot of things here. There are a lot of things that are telling me that this is not working really well, right? It's the contours of the tooth, how the implant is placed, and by when I remove the crown, I see, of course, this as a cement retained crown, and you can see there's a lot of cement. There's a lot of residual cement underneath. Okay,
Wow, that's a
and
great photo right there, Jorge.
yeah, it may not be, there are a lot of things in this implant that will tell me that why there will be explaining why he's having all these issues. But definitely the residual cement is one of them. Okay, it's not only residual cement, it's a lot of things. But this is, you can know this is contributing, of course, majorly to what's going on right here. Okay, so after the implant is removed, we graft the area, and we make sure we put some bone and membrane, and this is how the patient looks like, I think a few weeks after the surgery. And you can see that now, of course, we have a huge problem of recession. This patient is going to continue having some grafts. Ideally, now with the conditions of those teeth, now we have to even contemplate the idea of ortho-extrude these teeth and bringing all the bone back, and then losing 2 more teeth, and then do a 3-unit, implant FPD. But we're in the process of considering the options for the patient at this point. Okay. Okay. So the other thing too is, sometimes even with cores, you have to be careful of the cement. This is another student case where we're trying to deliver the 2 crowns. So you can see that even with the cord in place, cement can flow underneath. All right. It really depends on the amount of the cement that you use on that crown. Okay. So uh, some things to consider about cement is that, for me, if you ask me, I would like to avoid resin cements. Okay, and the reason is that they're just difficult to clean. Resin cements are difficult to clean, and that's a fact. Okay, I don't know about you, but in my practice, when I do restorations that I use a resin cement, I like those margins to be super gingival. Okay, because remember that resin cement is resin, right? It acts like a class 5 composites. You need to finish the margins. You need to, remove that oxygen inhibition layer. You need to polish those margins. If the margin is a millimeter subgingival on the facial, how am I going to reach it? It's going to be impossible for me, and to have a smooth transition between the restoration and the abutment. It's going to be impossible for me to do that. Okay,
Not to
unless,
mention, not to
yeah,
mention the uh, how the cement is affected by curricular fluid present in that area. And if you don't have really good rubber dam isolation, how can you how would you be able to know if your cement is really truly polymerized?
exactly. So for me, when I use resin cement, resin cement for me is it goes hand to hand with rubber dam, right? It goes hand to hand with isolation, polishing, finishing of the margins. If I have a subgingival margin of 1 millimeter in my hands, I am not, capable capable of actually finishing that restoration. So resin cements are out of my book when I use implants. Okay, when I deliver implant restoration. Okay, no, you have some options too. You can use zinc phosphate, you can use zinc oxide, right? You can use, tampon, temporary cement, RMGI, and polycarboxylates. This is a discussion that we had, Mario, a
Yep.
few weeks ago. And Chandra Watwani is always talking about this, and it's a very interesting talk if you have the chance to hear him. Actually, polycarboxylates in the instructions tell you not to use it for titanium because there's a possibility of corrosion. Okay, now I looked through the articles that he published, and he has a few in vitro studies where he actually shows some corrosion of the titanium when it's used in combination with polycarboxylate, which is Duralon, right? Duralon is a
Right.
very popular cement, okay? So that corrosion may lead to contamination of the surfaces, implant failure. We just don't know really. We don't have the evidence to say that, but it's something for us to consider. The instruction says actually that they may cause corrosion. I don't know if it's the best choice to cement our crowns
For
when
sure.
we use a cement retained crown. So something for us to consider. I couldn't find any clinical evidence that it will cause corrosion. I never seen it myself, right? We're talking the other day, and you say, I seen crowns that were cemented with Duralon for years, and then I removed them down the road, and I didn't see any corrosion. So I don't know the answer to that question. I guess we'll see with clinical studies.
For sure. And when I was talking to you about that, where those were actually my own restorations that I had cemented on my own patients. And that's something I mean, I like using polycarboxylates because if I need to retrieve the crown, it's a retrievable option. Now, when I was doing that, I was not aware of the issue that you presented to me. So yeah, that's for sure something that we have to look into and see, have a little bit stronger evidence as well to see what the causing factor is. Because you mentioned when we were having the discussion that one of the things that he had stated was the presence of fluoride in these type of cements, but fluoride is also present in resin modified glass ionomers, and
Yeah.
fluoride in both of these products is present at the beginning of the matrix, but then with time it declines until it dissipates, it completely dissipates. I mean, it just disappears. So
Mhm.
that's the only question that I have, but for sure we have to look into that and make a really good clinical decision.
You're absolutely right. Absolutely right. Those are things that we have to consider when it's time to recommend a cement like this, for sure. So another important detail is also make sure you're using a radiopaque cement, so you can make a PA and just verify any residual cement left. Remember also that if you're gonna cement these restorations, you have to have an abutment that has retention and resistance. You're not relying on bonding anymore, just like you do, with a bonded restoration. You don't have to rely on the height of that abutment, right? So just like the preparation of a crown. All right. So how to apply the cement? So when you're gonna use the cement, I like to use just a micro brush, okay? And also another thing about what Wani says is how do you actually apply the cement? He shows a very interesting in vitro study and some computer simulation where if you actually place the cement a little below the margin, okay, and you just paint the surface of the intaglio, you have less probability of that cement extruding too much, okay, versus if you put it at the bottom. So if you put it at the bottom of the restoration, I mean all the way to the intaglio, then you have more probability of that extruding and creating some residues that you don't want. All right. Another important thing to take is that when you put it around the margin, it's like if you fill this cement all the way to the top, flush it, that will be 100% of cement in there, right? It will be filling the whole space. What you actually need, you need about 3% of that. So imagine that. All right, if you fill it all the way to the top, 97% of that excess will flow out of your restoration.
It has
Imagine
to
that.
go somewhere. It has to go
It has
somewhere,
to
right?
go somewhere. It's gonna go somewhere. All right. So I think those numbers, because my mind works like that, right? In terms of, I like to see numbers, and they will tell you something. You need about 3% of that. So for me, that's great information. So you can also pack a cord, like I said, or use an analog. Okay. And I'll show you some other tricks about that, about the analog. My Wadwani and my friend Alfonso Pinheiro, they published this article, years ago about how to create an analog out of the crown. All right, they actually, Alfonso and Jonathan Esquivel, okay, they actually published sort of like a revision. I think they published it last year, or actually it's coming out the article, and they were kind enough to share this information with me. So here's another way to do it. Okay, so here you have the abutment. All right, this is the final abutment that you put on an analog. Then you cover the screw axis with a Teflon tape. All right, then after that, you put a little bit of PBS impression inside the crown. What is this doing? This is creating the space for the cement. Okay, it's sort of like a space maintainer for the cement. All right, and after that, you create sort of like a dye. All right, out of integrity. You put a little drop of integrity right there, and then you put a micro brush inside, and then you have created a copy, right, of the abutment. Now, after that, you peel that PVS adhesive, and now you cement your crown. This is, of course, done extraorally, right? You cement your crown on that abutment, you remove the excess, and now you take that to the patient's mouth. So now you have effectively, kept that 3% that you need inside the crown and just leave all the residue behind. All right. So it's a nice trick.
That is an excellent tip.
Yeah.
Very well described. That's a really good information because you will have cases that you're going to need to cement your crowns, and this would be a good way to help you control the excess cement. Because you're right. I agree with you, and I appreciate you sharing that information because when you say 3%, in your mind it tells you, it gives you a number that you can now relate to, and you know that if you have cement everywhere, that's 100%. 3% is, it's a lot less.
Yeah.
Very small amount of cement.
Yeah. Exactly. Exactly. Um, so another thing also to discuss is also the retrievability, right? How I'm gonna retrieve this restoration, and that's another thing that we discuss when we are using cement and versus screw retain. Okay, I want to be able to retrieve my restorations. All right, and that's why screw retain is always gonna be my first option. But there are situations like the one I show you that where you cannot do screw retain. All right. So now important thing to consider is that when we have a complication, and it's something that we need to discuss with our patients. The number one biological complication is preimplantitis, right? Preimplantitis and premicusitis is something that we're definitely going to see on our patients. Okay. Um, and when we talk about biomechanical complications, there are complications that are related to single crowns on FPD. Now, if we look at the evidence, you have a higher incidence of complications in crowns versus an FPD. And sometimes, I think that the reason why we see that is that because when you're doing an FPD and one screw gets loose, or you have an abutment that has a problem, the other one's still in place. So sometimes that actually, flies undetected, right? Because the FPD is still in place, and then only ones get loose. Okay, but the number one complication that you're gonna see is, of course, screw loosening. Okay, it's going to happen in about, I will say 10% of your patients, depending on the studies, go 7 to 13%. Um, it happens more in external connection. It happens more in single unit compared to FPDs. It happens more in the posterior region. It affects cement retain and screw retain, of course, like but you have more complications, more technical complications on screw retain versus cement retain. Cement retain is more related to leaving cement behind and creating,
Biological, more
yeah,
biological issues.
exactly. Um, Another thing also important is that you know, based on this study by Cordis, they also look at some information about original components. And for me, this makes a lot of sense. Okay, I don't think I can tell you that, you know, using original components you're gonna have less screw loosening. All right, but there's something called the settling effect. Okay, the settling effect. All right, and the settling effect describes that when you torque your screw, all right, you're gonna lose about 2 to 10% of that screw torque. After you finish the restoration and you put those 35, you're gonna lose about 2 to 10%. All right, due to that can be influenced by the roughness, by the hardness of the components, by the amount of load that you put on the tooth. There are many things that can affect that. Okay, but the companies are always investing money in research, doing tests, so they can improve that. So you have less, less loss of torque down the road. All right, but these are bunnies, big companies that have the money. Small companies don't do that research. They don't have the technology to do that. Okay, so for me, I sleep better when I use original components. Okay, because I know that
Right.
those parts have been tested, multiple times, many times, to make
And
sure we
then
don't lose that
the other
horsepower.
thing, is that there's some studies out there that have shown not only that these companies, they have the money, the resources to do the research on their own designs, but most importantly, when you have these, you know, uh, what would you call these companies, like you know, uh,
Generic, yeah,
right, like
that's
these,
right.
right, these other companies that are making these parts that can fit a certain brands of implants. The way that these components come together, there's a lot of studies that have shown that it's not an intimate contact, that sometimes you find a little bit of discrepancies within the shape. So there is contact, but then there's not intimate contact, and that lack of intimate contact is what can create the other issues of loosening of the screws and sometimes even fractures of the components because of that.
Absolutely, absolutely. The other thing is also that also scrutiny is also related with occlusion too and cantilever. So if you have a posterior interference, of course that relates to more scrutiny. And the other one, and the last one is bruxers. We know that also bruxers are a higher risk of not only screw loosening, but also chipping of the porcelain, fracture prosthesis, screw fracture. This is a clinical study that match the data patients with bruxism and the other patients with not bruxism. And of course they found that bruxism will increase the risk of having all those issues. All right, so it's very
Right.
important that if you have a patient that you can diagnose bruxism or clenching, it's better that they receive an occlusal guard after the treatment is done, even for a single restoration. If you think that your patient has bruxism, recommend an occlusal guard. I think it's a great option. So now when the screw comes loose, especially in a cement retained restorations, and here what you can do is you can take a radiograph and trying to orient yourself according to the implant axis, so you can sort of like fish or do a root canal on that implant crown, so you can find the screw, because it's when the screw is directly underneath, it's really easy, right? But when it's not, and the patient is not yours, so you don't have a picture or something to relate, this can be very challenging, if you want to keep the restorations, right? Uh, Another way to do it is this is an article that we published a couple of years ago, when I have a patient of mine that had a cement retained crown on a posterior tooth. And then since I made the crown myself, I had the master cast. You can just put that on a surveying table, and create just this sort of like PMMA acrylic, sort of like a stent, and drill to that, and then take that to the patient's mouth, drill for the stent, and then create an axis. Okay, this can be really helpful, and that's why when I do even a single restoration, I want to keep that master cast for as long as I can, just in case I need it someday, right? um
That's a really good tip. And today with today with the technologies that we have today, if you're doing a lot of your things digitally planned, you can keep your scans, you can save your scans, you can save all that information, and that will help you create these jigs as well. But that's a really good idea.
yeah, another thing, Mario, also that we're just becoming aware in the last couple of years is the interproximal contact loss. Okay, and this came to me a couple of years ago, and it's been an interest of myself. We are in the process of writing a few papers with some colleagues right here, but in this study right here, they look at 174 single implant restorations at Columbia. Okay, and they evaluated those patients for 3 months to 11 years. And when they saw on those patients, on those single implant restoration patients, that 52 of them lost or had open contact in those follow-up appointments. Okay, most of those contact losses was on mesial versus distal, right? So you will see more open contacts in mesial. This is post insertion, right? So the
Right.
crowns were cemented where everything was delivered and finished, and then the contact open later on. Okay,
And
and
this
then
is
if you
related
look,
to the natural neighboring tooth.
absolutely, absolutely, yeah. So we have that, anterior component of motion that's moving mesially, right? Um, and so if you look at the literature, another study reported 52%, another study 50 more than 50% as early as 3 months after the insertion, another 43%, 54%, 65%. This one right here by French reported a lower number, but it's also related to the way the open contacts were measured. Okay, so that's all, why you see the lower numbers. And we're doing a study. Well, I cannot say that. One of my colleagues is doing a study right here at the school, and she's reporting the same numbers. Okay, so
Wow.
you know in the article that she saw around 112 single crowns. 48% of those patients also lost proximal contacts. Okay, and 33% they were even not aware there was something there. Okay, so dear colleagues, this is a conversation that we need to have with our patients. It's crazy to think that 50% of the crowns that you make today, they're gonna lose their proximal contact, most probably mesial proximal contact, in the next 10 years. 50% of them. Okay,
And
so
the problem with that, Jorge, is not only that you lose the contact, but now you have food impaction. Now you have more biological issues to that implant as a consequence. Carries to the neighboring teeth. I mean, you can just put the list will just grow, grow, and grow.
yeah, absolutely. So another reason why to actually keep our restoration screw retained, because if you have that opening of contact and you notice on a follow-up, you can either, I was talking about this with other colleagues and say, in my hands, I will prefer just to add. You don't have to prep really, a composite, a class two cavity on that neighboring tooth. You can just etch it, put a little bit composite in that. You don't have to prep the tooth. Some other people will feel more comfortable adding ceramic, or actually adding composite to the actual porcelain crown. That's not the way I like to do things, but some people are feel very confident by adding actually composite to the porcelain crown, which I think is a preference thing. I guess also we'll see with time what happens, right?
Well,
But
but
in
the
my
beauty is
opinion,
that if you have a screw retained restoration, regardless of the technique that you want to use, you can take it out, you can send it to the lab, do it yourself, whatever you want to do, but you're going to solve the problem.
correct.
If the crown is cemented, you're
Uh-huh.
almost done.
Yeah, if you're crown cemented, then the only thing you want to do, if you don't want to remove the crown, the implant restoration, you'll have to prep. You have to prep a class 2 on the patients, which is not the ideal thing, of course.
Exactly.
Okay. um right. So when we were also talking about is that when you do a cement restoration, the nice thing about this custom abutments is that you can control those margins, right? I when I do cement restoration, I don't use the stock abutments anymore, and just because you cannot control the depth really of those margins, right? You cannot control how deep those margins are, and remember, you need to have margins that are, that you can access so you can clean the residual cement. Okay. So again, it's an important thing to do when you're in this phase of the design of the abutment. You can really control where the margins are going to be located at, right? And then after that, you can even verify the thickness of the restoration with a putty matrix or something that you want to. Okay. So another thing to consider when we're doing the restorations is how much interclusal space you have. Okay, remember that when you're doing cement retain, ideally, right, by going by the book and the thickness of the materials by the book, you need about 4 millimeters of height of that posterior abutment, so you can have retention, right? And then you need about 2 millimeters of the material occlusal, and then you also need about 2 millimeters of volume width. So more or less, you need about 8 millimeters from the opposing occlusal plane to the platform of the implant, right? You need about 8 millimeters. If you have less than that, you may be thinking about doing screw retain, okay? Now there are this designs where you can do sort of like partial crowns and then bond something on the facial, right? Sort of like a veneer. I haven't done design like this. I think I don't feel comfortable enough yet to do this. And again, if I will consider doing this, I will have to have the margins super gingival outside the gingiva so I can finish them the way I wanted to. So for me, I still see a lot of limitations when I do things like this. All right. So let's talk about a few things about screw return restorations. Okay. So now the problem of the access hole now is changed because now I have to deal with that on lingual, right? And that's where we want to hide it, right? We can retrieve it because it's just a screw return restoration, and then this is not limited by the space, right? Because we're not thinking on retention and resistance. And now we're going to talk a little bit about what is this screw angle channel option, right? And I think now I see it more and more, Mario. This is very popular, at least where I work, the environment that I
Yes, no, no, no. I
work
agree
at
with you. I see it a lot too.
is very, very popular. Okay, so this has been out, for a few years now. I think Nobel and Astra were the ones who started all this. Um, and if you go from the website of the company, they give you up to a 30-degree inclination, a 30-degree off axis inclination, where you can access the screw. And the way this works is that they provide a different screwdriver where it connects to the screw in a different position, right? So they call it this hemilobular screwdriver, where they can actually connect to that screw in a different angle. Okay, it doesn't have to be straight. Okay, that's why it gives you that sort of like range of degrees that you can access and still keep a screw retain restoration. What the thing that we don't know is, well, how much, right? They offer you up to 30 degrees, but some of the things that I see is that when you change the position to that, and then you go and when you have some of degrees, that can be okay, but when you have very extreme degrees, you start having some issues. One of those issues that I see is also the thickness of the materials around the neck area, right? Now, because you have that, exaggerating of angle situation, you are not able to keep, emergence profile like this. Remember that when we are doing our implant restorations, we want a emergence profile that, facilitates the resting of the tissue right there. You want a concave shape, right? Especially on facial, when you want the tissue to rest in this place. When you have this off angle, angle screw channels, this part it starts to be too thick, all right, and when it will not allow you to do those sort of contours that you want to. The other thing too, Mario, is that when we look at the literature, I look at the papers that were published, and I try to look for complications. I couldn't find much of clinical studies. Most of the things that I found were in vitro studies. This was one of the clinical studies I found when they show 84 single implant crowns with this angle screw axis with about 4% of complications. So about 3 patients develop complications like screw loosening, okay, after 10
Right.
months, okay. What you're gonna find is more of like these studies right here, studies that were done in vitro, and they were looking at reverse torque values, okay. So how they work, they have a group of screws that they torque to with a restoration and to an analog to an implant, and they torque them to, I don't know, 35 or 25, whatever the company tells you, and then they measure, with a reverse torque value, how much torque it needs to to become,
To
on torque.
unscrew, right? To be
Exactly,
to
unscrew,
become
right?
loose.
So this article looked at 0, 10, and 20 of these angle screws, okay, and found statistical significant difference between 20 degrees. So in other words, is that if you have 20 degrees, off angle screw, you start losing the torque. All right, the torque force, the torque value that you have put in that screw start getting looser. Okay, at 20 degrees. All right. This study right here look also at the same thing again in a in vitro sort of environment, and look at a straight screw and this angle screw at 0, 20, and 28. This article by Jack Goldberg also um, they didn't find any difference from the statistical point of view. Okay, but of course again they saw that 28 degrees had the lowest numbers of torque values. All right.
Now, one thing that
um,
I do want to comment here on these studies is that I do believe that their value, even though they're in vitro study, is good. Because if you think about it, in vitro studies, when you're screwing a crown in the mouth or on a model, it's the screw that's what the one
uh,
that you're measuring. There's nothing
exactly.
else that's helping that screw to stay in place. It's not like the tissue, the bone, and the implant. That's not going to help in any way. It's the actual torque value of the screw, which is going to keep that crown in place for a longer or shorter period of time without having a screw become loose. So
Mhm.
even though we want to get these studies and take them to the clinical reality, I think that the information that they're giving us today is very valuable. And it's
Mhm.
valuable because it's the only thing we have. And it does make a lot of sense that if you're off angled, it's going to be more difficult for you to achieve a higher torque value. It makes all the sense in the world.
Absolutely. Look at this study right here. This study, also another in vitro study, uh, where they were looking at 5 different angulations, okay, and again, measuring the reverse torque values. They look at 0, 10, 15, 25, and 28, okay? Interesting thing about this study is that on the first three, the 0, the 10, and the 15, they didn't find any difference, okay? But as soon as you go over 15 degrees, 25 and 28 degrees, you start again losing those torque values. So we keep seeing this information over and over, Mario. Another interesting thing in the study, look at that, the damage that that screw head will receive if you go on that 28 and 25 degrees, all right? And that's something I see clinically. We were talking about this the other day too. I think, when you have those extreme angulations, really, you cannot, if it feels that doesn't engage, the same way, right?
It feels like there's something spinning there, and you are afraid of damaging the screw.
Uh,
Because once you damage the head of the screw, you're done.
exactly, exactly. So that option of being retrievable can be eliminated when we have a problem like this, because you will not be able to retrieve it anymore unless you cut the screw out. So
Exactly.
it
You're
may
right.
be a very difficult situation. And this screw is angle. How are you gonna get it? You need to remember that you need to, when you cut that screw, you're using a straight burr. How are you gonna get it? It's
Exactly.
gonna be really hard to do. Okay, I haven't had the chance to cut those angle screw yet, but hopefully,
Yeah.
that's not gonna happen. So another interesting thing when I was looking at this evidence, Mario, is I got the chance to see this article, and I haven't seen an article like this before or something like it. Okay, these articles were looking at the screw values when that screw was contaminated by blood, saliva, chlorhexidine, with all this liquids, and they were looking and they were seeing that the results that were showing the article is like those liquids act like a lubricant. Okay, so if the screw is contaminated, you're gonna lose some of that torque force according to this in vitro study. So
And
it
this is on straight axis. This is even on straight axis implants. So this is for any screw.
right. This is for any screw. So it makes sense, it makes a lot of sense to me that before you torque that screw, make sure it's completely dry. Make sure when you put that Teflon tape to seal the access hole, this is completely clean, completely dry. You don't have those contaminants. I mean, it's something so small that you can do that can have an impact, in the future. So I think it's
For sure.
something we should definitely consider. Okay, so I'll show you here, and with this, we will finish the presentation. One of the cases that I treated on the faculty practice. So this patient has an RPD, and she wants to place implants on those missing spaces. She also wants to change those restorations. Um, so this is a patient we need to do a full mouth rehabilitation. Okay, there are many reasons why I chose to do that. But I cannot really. I right now I can just go through the main points right here, right? But we also
Exactly.
have to
Yes.
increase the vertical dimension of this patient, give her some rooms for restorations. Um, this is how she looks like right now. She does have some, some bone right there, some soft tissue, but you can see that I'm a little tight on space. So here are the radiographs of the patient. Here's the my diagnostic wax up that I work with the lab. Then I start doing all the ups, removing all the restoration, so I can start working on my buildups. And after that, the implants are placed. I like to do all the surgical part and then take care of the teeth. Okay, so the implants are placed, then provisionals are created, and then I have provisionals in the other two and the other teeth. I also I am training my soft tissue so I can have the contours that I want with my provisionals, and after that I make a final impression of those surgical sites that I develop with a custom made impression post, and then I have my case right here. This is an angle. I think this is a great case for those angle screw restorations. The other day I was listening to a Instagram live from Steven Chu, and they were talking about the same thing, about the same thing, the same studies about screw angle channel, the same ones that we just discussed, and they were getting to the same conclusion. And they were saying, if 15 degrees will be about the incisal edge. If the screw axis will come out at the incisal edge, you can use screw angle axis. But if that goes through facial, that's beyond 15 degrees. So
Right.
it's a very very nice clinical tip to decide. Okay, when can I use it? Because if I tell you more than 15, okay, how much is that? How would I measure that? But that makes a lot of sense, right?
Right.
15 degrees, if you are over the incisal edge and you're on the facial, then it will be too much. All right. So for me, it makes a lot of sense because, I done restorations where I had a straight screw, but the incisal edge was so thin, right? That you become really scared actually to do that because remember that you don't have much porcelain right there.
And I think
So
that this is the case that you're showing right now. I saw those implants; they seem to be fairly well placed in a good longitudinal axis. So this is more of you gaining more thickness of your material, and that's why you decided in this particular case to use your angle screw channel.
correct. Exactly. So we went from this to this right here. So the patient's smiling picture. And we can see that we provide the patient with full contour monolithic lithium silicate restorations with just a little bit of micro layer on the incisal. So we recreated. We don't really need a lot of translucency on her case. She's a middle-aged woman. We are more concerned of having this balance of soft tissues restoration. Making sure she understands how to clean her restoration, how to clean her prosthesis, and make sure we will have this for a very long time, So those are the side pictures. Here are the occlusal restorations and how she was. She was very happy with the end result.
Beautiful,
It-
beautiful restorations, beautiful ceramic, and very well planned case as well.
yeah, this is done by Bill Moraes. He's a fantastic lab technician here in the Portland area. Here, this is what we have. It's been about 3 years that we finished that case, and then we finished with an occlusal guard. And for the conclusion of the lecture, I want to tell you that you can use cement retain, but use cement. Again, my first choice is screw retain. But if you're gonna use cement retain, be very mindful of the cement that you use. Be very mindful of what is the strategy that you're gonna take to minimize the residues of cement that you leave, in the sulcus or around the restoration. Use screw retain if possible when you can retrieve it. But if you're gonna use screw retain, if you're gonna use a screw angle channel, make sure it's not beyond 15 degrees. Um, and also with a higher angle, you have more possibility of deformation of the screw and also having screw loosening and complications in removal. Okay, and also make sure that that the screw head is completely clean before you seal that access. Okay, so with that, Mario, I want to thank you very much. And here's my contact information. If you have any questions, just please let me know.